महेंद्र ऐसे लिखा रहा है OBS has crashed. Would you like to copy the crash? Okay. ठीक ठीक. Okay, yeah, hello guys, good evening all of you. I hope I am audible and visible. Audio video fine. Confirm कर दो एक बारी सब लोग, and then we are going to start. Okay. So guys, in this class we are going to discuss about some important MCQs, which are important MCQs from the important topics in pharmacology. These are basically predictable topics for your exam, for your NEET MDS exam. So please revise these topics before going for exam, and obviously these MCQs are very important and they are going to help you in your exam. So let's start with the first question. Question is, sir, which of the following drug is commonly used for conscious sedation in dental procedures? You know, when you see the exam, in almost every exam they are asking some drugs from the anesthesia, and one of the very important drug they are asking in your exam is midazolam. So this is the drug which is commonly used for conscious sedation. So you can see the word conscious sedation in dental procedures. So basically this midazolam is one of the shorter acting benzodiazepine, and yes, it is the shorter acting benzodiazepine. And guys, this drug is wonderful drug for all the daycare procedures in daycare. Why it is important? Because midazolam is not only sedative, it is also causing amnesia, as well as it's a good muscle relaxant. So because of these multiple reasons, midazolam is the wonderful drug for this purpose. And you know what is the route of midazolam? Other than IV route, it is also available in the nasal spray form. So with sedative is available nasal spray, that is also midazolam. Diazepam is longer acting drug. Lorazepam is the wonderful drug, and the best thing about the lorazepam is it is safer in the liver disease patients as well. In liver disease patients as well, it is safe. That's why lorazepam is safer, as well as the chances of recurrence of seizures will be less with the lorazepam. So it is the drug of choice for status epilepticus. The lorazepam is the drug of choice for status epilepticus. So status epilepticus, the drug of choice is lorazepam, we used via IV route. If they ask you the drug out of these which can be given via rectal route, then go with the diazepam. Diazepam is the drug can be used in the febrile seizure patients. It is the drug of choice. Febrile seizures means high grade fever causing seizures, commonly seen in children. So in that we use via rectal route. Midazolam is available in the nasal spray, as I told you. So these are some important questions. So don't forget to revise the barbiturates and benzodiazepines, their difference, and then what are the uses of benzodiazepines. I hope all doubts clear. चलिए next question कर लेते हैं, means next topic कर लेते हैं. Which of the following drug is a selective COX-2 inhibitor that can be prescribed for post-operative dental pain? So in dental pain we need the anti-inflammatory. drug as well. So we need anti-inflammatory as well as good analgesic, right? This type of drug we need. They are saying ki sir, selective COX-2 inhibitor. You know what is the disadvantage of COX-1? Due to COX-1 inhibition, if the drug inhibit the COX-1, that is not safe for stomach, so it is causing lot of gastric side effects, and that's why selective COX-2 inhibitors are causing no gastritis. So what is the benefit of selective COX-2 inhibitor? No gastric side effect. No gastric side effects are there. That is the benefit. So when the patient is having risk of gastritis, ulcer, definitely you can use them, right? So now comes to sir, which drug out of these we are using for this purpose. So bachche, what is tramadol? Tramadol is the opioid drug. Naproxen, etoricoxib, ibuprofen, these drugs are NSAIDs, non-steroidal anti-inflammatory drugs. And out of these, when the coxib word is there, coxib word is there, then these are the selective COX-2 inhibitors. These are the selective COX-2 inhibitors, because selective word is there. So these are the selective COX-2 inhibitor, right? Is that fine? Is it working? Okay. So etoricoxib, in the last I will solve all your doubts, right? Right now please focus on the topic which I am telling you. I will take your doubts in the end, otherwise I will be distracted. So etoricoxib is the selective COX-2 inhibitor. Then we have the naproxen, ibuprofen. These are the non-selective drug. Ibuprofen is one of the safest analgesic and anti-inflammatory in the pediatric patients. So ibuprofen is good anti-inflammatory for pediatric patients, or you can say in the children. Overall safest analgesic is paracetamol, but you know paracetamol is not anti-inflammatory. That's why we are saying ki sir, this ibuprofen is the safest anti-inflammatory in children. If they ask you safest analgesic, then go with the paracetamol. Okay? So these are important question from the NSAIDs. Next question: which of the following chelating agent is used for the treatment of acute lead poisoning? Again, very important question, acute lead poisoning. So guys, which drug out of these used for the acute lead poisoning? Very important, acute lead poisoning. Options are deferrioxamine, see the word ferro, deferrioxamine. Then you can see EDTA. Then you can see penicillamine and dimercaprol. What is dimercaprol? Dimercaprol is also called as BAL, British anti-levisite. So remember bachche, this is British anti-levisite, BAL. All these are chelating agents. So how to remember? BAL, remember माँ, बाल माँ बोलते ना, बाल बच्चा और उसकी माँ, तो बाल माँ. तो M for mercury, and A for arsenic. For these two it's a wonderful drug. Now comes to next. What about the penicillamine? It is wonderful for copper. EDTA, calcium disodium EDTA. This is wonderful for lead. In lead we also use succimer. And desferrioxamine, that is for iron, ferro. So don't forget to revise these chelating agents, especially the lead, iron, copper and mercury, arsenic. So these are the important. Okay. Now, ठीक है बच्चे, now comes to next important. Next is this one. Which of the following dental procedure does not typically require antibiotic prophylaxis? In a patient with history of prosthetic heart valve, you know prosthetic heart valve is there. In prosthetic heart valve, we definitely need the prophylaxis. So they are saying in which dental procedure the prophylaxis is not required. Options are tooth extraction, periodontal surgery, scaling, root planing, root canal treatment. So where the risk of bleeding is less, or you can say the procedure is not very strong. So if you see out of these, tooth extraction, periodontal surgery and this root planing, in these the bleeding is more, so we need prophylaxis. So prophylaxis required in these conditions. But in root canal treatment, in RCT, it is not required. In RCT, it is not required, right? So this is one of the important thing in prophylaxis. We need to follow these rules. And you know which antibiotic is best for prophylaxis? Then amoxicillin. Amoxicillin is best for prophylaxis. Otherwise, there is a risk of infective endocarditis. Now comes to next. Which of the following is the primary advantage of using nitrous oxide? So very important again, nitrous oxide is one of the drug which can be used as a sole agent in dental surgeries. Can be used as a sole agent. So use nitrous oxide as a sedative agent in dental procedures. Options are, it is having high potency. No, it is not high potent. It is less potent drug. Rapid and short duration of action. Yes. It is strong analgesic drug. Not very strong, but yes, it is good. Not very strong, but it is good analgesic drug. Non-sedating effect. No. So because of rapid and short duration of action, it is used as primary sedative drug in this patient. So guys, alone or sole agent, it can be used in the dental surgeries. It is good analgesic. It is good analgesic and poor muscle relaxant. Good analgesic and poor muscle relaxant. Good analgesic, poor muscle relaxant. The risk with this is diffusion hypoxia. When you stop nitrous oxide infusion, it is going to diffuse in the alveoli from the blood coming to alveoli. So what happens? सोचिए blood से alveoli में, so it can replace the oxygen, and that's why there will be hypoxia. So that's why when you stop, you give the oxygen. High flow of oxygen has to be given with it, otherwise there will be risk of diffusion hypoxia, right? So now nitrous oxide is one of the drug which can be used. Otherwise it's a carrier drug. It is used as a carrier, not the alone drug, but in this it can be, right? Okay. Next, which of the following antibiotics may have an interaction with warfarin, increasing the risk of bleeding in dental patients? A patient on warfarin, don't forget to revise the warfarin and the newer anticoagulant. One of the frequently asked question is anticoagulant, heparin, warfarin and the newer. So in warfarin, interactions are very important, because if the patient is on warfarin, now you give the antibiotic. Now just think logically. If they are asking in dentistry Then which antibiotics you guys are commonly using? You guys are commonly using two group of drug. One is penicillins, or you can say the beta lactams, and the another is metronidazole. These two antibiotics are commonly used in dentistry. Amoxicillin group of drugs does not cause interactions because amoxicillin does not have, or penicillins, cephalosporins, they do not have CYP interactions. They are not CYP inducer, they are not CYP inhibitor. So guys, this amoxicillin is definitely not having any CYP effect, so no interactions with the warfarin, because this warfarin is metabolized by CYP2C9. The name of the enzyme is CYP2C9, right? CYP2C9. So out of these, the drug metronidazole, it is having CYP2C9 inhibitor. Just think, if it is inhibiting this enzyme, what happens? That leads to suppressed metabolism of warfarin, and that leads to increased warfarin effect. So what is the risk? There is risk of bleeding. So which antibiotic increase the risk of bleeding? You can see it is metronidazole, which can increase the risk of bleeding due to this. Even with the ceftriaxone, there is risk of bleeding because both can cause thrombocytopenia. So ceftriaxone can cause thrombocytopenia. Because of that, there will be risk, but that is not the direct interaction. That is having its own effect, thrombocytopenia. That is one of the third generation cephalosporin. Got it? So these are important questions with the warfarin drug interactions. If they ask you the newer anticoagulant, then don't forget. If they ask you DTIs, direct thrombin inhibitor, then one dabigatran, that is oral. And if they ask you 10th A inhibitor, then don't forget rivaroxaban. So you can see in the suffix you can identify. See the name, xaban. All these drugs will have xaban. Xaban means 10th A. And tran or troban, these are thrombin antagonist or thrombin inhibitor. So these are DTIs, direct thrombin inhibitors. So don't forget this. So the correct answer in this is metronidazole with the warfarin. INR monitoring is required, so you need to adjust the INR. You know what is the value of INR with warfarin? What is the value of INR with the warfarin? So it should be maintained between 2 to 3. And it is the vitamin K epoxide reductase enzyme inhibitor. Vitamin K is the antidote for warfarin. One more important interaction with the warfarin is when you use the warfarin and you have given the broad spectrum antibiotics. So sometimes what happens, due to these broad spectrum antibiotic, they can suppress the gut flora. And if they suppress the gut flora, like ampicillin can suppress the gut flora, like tetracyclines can suppress the gut flora. So these are broad spectrum antibiotics. So because of that, vitamin K production will be less. And if the vitamin K production is less, then what happens? Then obviously antidote is less, warfarin effect will be more. So with antibiotic, the risk of bleeding is because of multiple reasons. Okay, don't forget to revise the classification of antidepressants and lithium. These two are frequently asked. So which of the following drug is classified as serotonin norepinephrine reuptake inhibitor, or you can say it is the word SNRI. Why it is important for you guys as well, I will tell you. So guys, fluoxetine is the best SSRI and it is the best antidepressants and best drug for anxiety disorders. Bupropion is the NDRI, norepinephrine dopamine reuptake inhibitor. Norepinephrine dopamine. So it is basically used as anti-smoking also. Duloxetine is SNRI. Amphotericin B is one of the antifungal drug. So out of these you can see it is the duloxetine. And you know why duloxetine is important? Because duloxetine is the drug. They are not only antidepressants. They are also used for neuropathic pain. So neuropathic pain patients, you can use the duloxetine SNRIs. What are the other important drugs for neuropathic pain? So for neuropathic pain, the other important drugs are, we can use the tricyclic antidepressants like amitriptyline. That is very effective drug. But the best drug is gabapentin or pregabalin. The best drug is gabapentin or pregabalin. These are best, gabapentin. In neuralgia, we can use the carbamazepine. In trigeminal neuralgia, we can use the carbamazepine. In trigeminal neuralgia, carbamazepine. What is the benefit of oxcarbazepine? Oxcarbazepine causing less side effect, but SIADH is more. More SIADH, rest of the side effects will be less with the oxcarbazepine. Now next question. Some clinical questions are also important. A 50-year-old patient present with white curd-like patches on the oral mucosa that can be scraped off, revealing an erythematous base, red color. Which of the following is the systemic treatment for this condition? As this is the recurrence in this patient, so we need to give the systemic drug. If they ask you oral or they ask you topical, which one you will start first? So obviously we will start the topical first. But in this question they are asking the systemic. So it means they are asking about the oral because recurrence is there. So topical you have the nystatin, or you have the clotrimazole. These are azoles. Clotrimazole, miconazole like drugs are there. These are azoles. But in oral you have the best drug, that is fluconazole. The very effective drug fluconazole, but that is only to be given if the topical drug is not effective. Then definitely you can use the fluconazole. So guys, terbinafine is not for this purpose. In oral candidiasis we don't use. In nails we use the terbinafine for nails. Ketoconazole causing lot of systemic side effects like gynecomastia. So because of side effects we don't use. Gynecomastia risk is there. Amphotericin B is again highly toxic drug. Electrolyte imbalance, bone marrow suppression, neutropenia, kidney injury. So many side effects are there. So fluconazole is the safe drug, and it is the important drug for candidiasis as well as cryptococcus, which is seen in the brain. So in these fungus we use the fluconazole, especially if the immunity will be low, there will be fungal infection. This fluconazole is the wonderful drug for this. If fluconazole is not effective, then we use the itraconazole. Okay. Next question, which of the following anti-epileptic drug? So I have selected the topics, and you can see from every important topic I have taken one MCQ. So you have to revise these topics. Again, I am telling you again and again, revise these topics. Only not these MCQ. These topics are very important. So which anti-epileptic can act primarily by inhibiting the T type of calcium channel? In anti-epileptic, there are two type of questions. Either they will ask you the mechanism of action, or they will ask you the this drug of choice or first line drug. So out of these, if you see the ethosuximide is the T type of calcium channel blocker. It is the T type of calcium channel blocker, and it is the drug of choice for absence seizure. Valproate is not the drug of choice for absence seizure. Ethosuximide is the drug of choice. If it is not available, or if there is atypical type of seizures, then only we think the valproate. Valproate is the broad spectrum, but primarily it is the sodium channel blocker, and it is the drug for GTCS, generalized tonic-clonic seizures. In the GTCS, generalized tonic-clonic seizures, we prefer the valproate. Phenytoin is also sodium channel blocker, but lot of side effects. It is not the first choice drug. Benzodiazepines, I already told you, drug of choice. These are the GABA receptor acting drugs. So these are GABA A, which is GABA chloride channel complex. Open the chloride channel, and these are drug of choice for status epilepticus or refractory seizures. In the focal seizures, we use lamotrigine or we use the carbamazepine. And nowadays one important drug is levetiracetam. Can be used for all type of seizures. Levetiracetam, it is SV2A blocker. Levetiracetam, SV2A, synaptic vesicle 2A, SV2A. So levetiracetam or brivaracetam, and that is safest in pregnancy. That is safest in pregnancy. So very good drug, levetiracetam. So these are some important anti-epileptics. In phenytoin, cerebellar toxicity risk is there. Gums hypertrophy is there. Which of the following chemotherapy agent is most commonly used in the treatment of head and neck squamous cell carcinoma? Very important again. In chemotherapy, definitely one important question. Magnesium sulfate is for eclampsia bachche. That is the drug for eclamptic seizures. When the hypertension is there in the pregnant ladies and then seizures occur, then we use the magnesium sulfate. That is for eclampsia treatment. That is not for epilepsy. In epilepsy, which type of epilepsy is there depend on that. So during pregnancy, levetiracetam can be continuously used because levetiracetam is very safe drug. Or if you are planning, then also levetiracetam can be started. So you can switch from the other drug to levetiracetam if you are planning. But if already pregnant lady comes, then we don't change. Then we continue. We explain the risk. So guys, one chemotherapy very important, especially head and neck cancer, so which are commonly used for non-squamous cell, the squamous cell carcinoma, head and neck cancer. So we use the cisplatin, 5-fluorouracil. We use these drugs, cisplatin, 5-fluorouracil. So cisplatin is the platinum compound. Cisplatin is the platinum compound, and they are the most toxic. They are the most toxic drug. Platinum, most toxic. They are the most toxic drug. They have the risk of nausea, vomiting. They have the risk of nephrotoxicity. They have the risk of ototoxicity. So highly toxic drug. And to prevent this toxicity, we use the drugs along with it, like ondansetron used for nausea, vomiting. Methotrexate. Methotrexate is the drug which is inhibiting the dihydrofolate reductase enzyme. So it is for folate, anti-metabolite, folate. Trastuzumab. Trastuzumab is for HER2 gene. HER2. That is for breast cancer. HER2 gene is for breast cancer. Cyclophosphamide is the alkylating agent. That is also used as immunosuppressant. Alkylating agent. So all these are commonly used chemotherapy. We should know some commonly used chemotherapy, especially the anti-metabolites and platinum compounds. So this classification of anti-metabolite: folate antagonist, purine antagonist, pyrimidine antagonist. Right? Okay. Next question. A patient develops a dry cough while on antihypertensives. Which mechanism is responsible? A patient on antihypertensive. So in antihypertensive, if the patient is less than 55 year or the patient is more than 55 year, we need to start the first line drug. I am talking about the essential hypertension. If the patient of essential hypertension, then definitely we start it. So if less than 55 years, then we start with the ARBs or ACE inhibitors. ARBs or ACE inhibitors, A. If the patient is more than 55 years or equal to 55 years, then we start with the calcium channel blockers, or we can use the diuretics, thiazides. These are the first line drug. If the patient is not having control, then only we can give the dual therapy, triple therapy, etc. So overall ARBs, ACE inhibitors for the less than 55, more than 55, we use the calcium channel blockers or thiazides. So when we start these drugs, out of these, cough is very commonly seen with the ACE inhibitors. Because it is inhibiting the ACE enzyme, so what happens? It increases the bradykinin level. And because of increased bradykinin level, what happens? There will be dry cough. And the only solution for this is dry cough, angioedema, So the only solution for this is change the drug. If the patient is having angioedema, then definitely you cannot continue. So then shift the patient to angiotensin receptor blockers. So ACE inhibitors are pril and ARBs are sartans. So shift the patient to sartan. In this diabetic patients, they are the wonderful antihypertensive. If they ask you antihypertensive for diabetics, then they are the best drug for diabetic patients. If they ask you antihypertensive for asthmatic patients, then calcium channel blockers are best. Right? So diabetic patients, asthmatic patients, and in pregnancy, the labetalol. In pregnancy, labetalol is the best drug. In emergency hypertension, we can use the nicardipine, CAR. Remember CAR for emergency, NICAR, CAR for emergency. The nicardipine or nitroprusside. Okay, very important topic, HIV, especially the post-exposure prophylaxis. A dental intern sustained a needle stick injury while treating a patient later found to be HIV positive. What is the most appropriate next step regarding the post-exposure prophylaxis of HIV? Very important. Post-exposure prophylaxis of HIV. Every health professional should know about the post-exposure prophylaxis. So what we do in post-exposure prophylaxis? We start the 3 drugs: tenofovir plus lamivudine plus dolutegravir. This is called as TLD regimen. So tenofovir, lamivudine and dolutegravir. Gravir is GRAGE inhibitors, lamivudine is and lamivudine and tenofovir is the NRTIs, nucleoside or nucleotide reverse transcriptase inhibitors. So TLD regimen is given. It has to be start within 72 hours and has to be given for 4 weeks. And then regular HIV testing at 0, then after 6 weeks, then after 3 months, then after 6 months we need to go for the HIV testing. So you can see they are trying to confuse you. Within 72 hours, okay. 2 drug regimen, no. 14 days, no. So this is false. Start within 24 hours using a 3 drug regimen or 28. It could be true because within 70 you have to start, but start as early as possible. ASAP, as early as possible. As early as possible. So it is not A, it is the B, which is correct. Wait for confirmatory test? No, we cannot wait. PEP is not indicated if the patient is asymptomatic? No. So it is the option B, which is absolutely fine. So start PEP within 24 hours. Yes, obviously, that is best. But at least within 72 hours. At least within 72 hours. Okay. TLD regimen, don't forget. That is also for the same regimen for the treatment as well. In treatment also we use the same regimen. Next, again very important topic, TB. Which of the exam is not over if the TB question is not there? So because TB is so common and you are a dentist, you are exposed to tuberculosis ketanu and HIV ketanu. Which of the recommended duration of B-PAL-M regimen, a new regimen approved by WHO as well as approved by the Health Ministry, Government of India, which is for resistant TB. So first, what is MDR TB? MDR means H plus R resistance. MDR means H plus R resistance. H is isoniazid, R is rifampicin. Then we use the B-PAL regimen. B for bedaquiline. B for bedaquiline, that is ATP synthase inhibitor. Then we have the P for pretomanid, that is mycolic acid inhibitor. Then we have the L, that is linezolid, that is protein synthesis inhibitor, and M is moxifloxacin, that is fluoroquinolone, that is DNA gyrase inhibitor. All these drugs are given for 6 months and all these are oral drugs. That is the beauty of this regimen, that all oral short regimen, all oral short regimen. So the 6 month is absolutely fine. That is for resistant cases. If there is fluoroquinolone resistance, suppose moxifloxacin resistance, levofloxacin resistance, then we use the B-PAL regimen. We use the B-PAL, right? That is M you can remove. That is also effective for the resistant cases, but B-PAL M has been approved by the Government of India for MDR multi-drug resistant TB patients. So don't forget B-PAL M regimen. Okay. Next, a woman taking oral hypoglycemic medication, diabetic medication, experience vulvovaginal itching. So itching in the vulval or vaginal region. What is the most likely causing this side effect? So guys, don't forget the anti-diabetic drugs. Very important. We are talking about the vulvovaginal, means that is risk of UTI, urinary tract infection, fungal infection, vaginal candidiasis. So that is seen due to glycosuria. That is due to glycosuria. And the drug which is causing loss of glucose in the urine is SGLT2 inhibitors. SGLT2. Sodium glucose transporter, SGLT2. In the PCT, we have this transporter. So what happens because of this? There will be glycosuria. There is loss of sodium, there will be glycosuria. So canagliflozin is the SGLT2 inhibitor. It is good for CHF. It is having the risk of, in CHF treatment we are using it, but there is risk of candidiasis or UTI. It's a wonderful drug. Glimepiride. Glimepiride is the sulfonylurea, and with sulfonylureas there is risk of hypoglycemia. Hypoglycemia is maximum due to sulfonylurea because they release the insulin. Voglibose, that is alpha glucosidase inhibitor. So only the gastric side, intestinal side effects will be there, inhibiting the digestion of the sugar. But this is important. Liraglutide, that is GLP-1 glucagon-like peptide, GLP-1 analog. Because of this, it will slow the gastric emptying. It will slow the gastric emptying, and that's why it will cause the weight loss. So it is approved as anti-obesity. Don't forget the two important drugs. One is semaglutide. Even though it is the peptide, but it is the first oral GLP. It is the first oral GLP-1. Semaglutide. That is also approved for weight loss, anti-obesity. And one drug is tirzepatide. Tirzepatide. That is also approved for anti-obesity. That is GLP and GIP. Dual. GLP and GIP. GLP is glucagon-like peptide, type 1, and GIP is glucose-dependent insulinotropic peptide. So in both there will be increased insulin. One is depending on the glucose, GIP, one is glucagon-like peptide. So these are anti-obesity as well. So the drugs causing weight loss, this one, and this one, these three drugs are causing weight loss. Weight loss is there. Anti-obesity approved. But out of these, the correct answer will be canagliflozin. Out of these, the correct answer will be canagliflozin. But don't forget liraglutide, semaglutide, and tirzepatide as well. Okay. Last question, then I can take your queries. 45-year-old patient is prescribed a drug that acts as a competitive inhibitor of the enzyme involved in the cholesterol synthesis. So basically we are talking about the HMG-CoA reductase enzyme. This enzyme activity is maximum in the night. That's why these drugs are given at the night. Statins. Rosuvastatin can be given any time of the day because rosuvastatin is the longer acting drug. That's why rosuvastatin is commonly used. So in the competitive inhibition, what is going to happen? What is going to happen? So first we need to know what is Vmax and what is the Km. So Vmax means maximum velocity So you can see the height of the graph. So that is also called as efficacy in the drugs. Km means it is the constant, it is the amount of substrate. It is the amount of substrate, or you can say the dose for half Vmax. So it is basically telling us about the potency, because potency is inversely proportional to amount. If less amount is required, means the drug is more potent. So now you can see in this graph, when the right shifted, you can see after giving the antagonist, the graph is shifted to right. Always remember, right means competition. In the competitive nature, you will shift to right. Good competition, healthy competition, you will be always right. Graph shifted to right, but the height is same, because in competition you will study more, you can achieve the same response. Your rank is still same, but you need to do the more hard work if there is competitive exam. So you can see the height is same. So in this you can see the Vmax is same. But what about the Km? So the dose for 50%. You can see this is the dose for 50%. This is the dose. This is the amount. So you can see the amount required is more. It means the Km has been increased. This is competition. So you can see the potency is decreased, but the efficacy is same. But in non-competitive, you can see this is non-competitive. In non-competitive, you can see the graph shifted downwards. It means the Vmax decreased, but the Km could be same, or it could be increased, but mostly it is same. For 50%, it could be same. So whenever there is downward shift, always remember it is non-competitive. Whenever there is rightward shift and the height is same, it is competitive. So you can see in this, in the competitive, the Vmax is same and the Km has been increased. So you can see in this, increase Km, no change in the Vmax. No change in the Km, decrease Vmax. Increase Km, decrease Vmax, no. So what is the correct answer? Option A. Increase in the Km, no change in the Vmax. Sometimes they are also giving this linear bulk plots for inhibition. In this you need to know, it is not the graph between the V or S. It is S means substrate, means amount, and V means same, the velocity. So you can see it is between 1 by V and 1 by S. So if the graph, remember, if the graph is like this, crossing, so in this you can see 1V is same, 1 by V is same, means Vmax is unaffected. But 1 by S means what? 1 by S means amount of the substrate, but 1 by S, it means opposite. So you can see the after giving inhibitor, this is 1 by S. This is 1 by S. So you can see when you see this 1 by S, it is in the negative direction but towards the 0. It means it has been increased. So you can see this, it has been increased. So the height is same but the graph shifted to right. So that means the height is same, the graph shifted to right. So that is competitive, same. Right shift means positive. Then in this you can see, if it is parallel, that is uncompetitive. There is no competition, uncompetitive. And the third one is non-competitive. In non-competitive, you can see the graph meet at this level. It means the substrate amount is same. So you can see the Km is unaffected, but you can see after competition 1 by V has been increased. So Vmax has been reduced, because 1 by V has been increased, so Vmax has been reduced. So that is non-competitive. So in non-competitive, it will be like this. In uncompetitive, it will be parallel. But in competitive, मारकाट मचेगी, याद रखना. तो कॉम्पिटिटिव में मारकाट मचेगी, अनकॉम्पिटिटिव में बिल्कुल पैरेलल चलेगा, और नॉन कॉम्पिटिटिव में अलग अलग डायरेक्शन में जाके आगे कहीं मिल जाएंगे, अलग अलग स्पीड से जाएंगे. So this is about this graph. So that's all. Now you can ask your doubts. This is my Instagram ID. Lot of information you will find in highlights regarding pharmacology. Dr. Dinesh Yadav. So बच्चे, now I can take your doubt. You can ask your doubts and please revise these topics. Whatever the topics we have selected, please revise these topics. Okay, one doubt was about the one question, angry baby syndrome, angry baby child syndrome is, that is beta midazolam. Angry baby child syndrome, it is the paradoxical effect. Usually we give the midazolam to calm down, but in some patients, especially children, we have seen the paradoxical means opposite effect. So Florence, so that's why it is called as angry baby child syndrome, and that is seen with the midazolam. So midazolam causing angry baby child syndrome, midazolam, angry baby. Anything else? In magnesium sulfate, I already told you about the magnesium sulfate, that is for eclampsia. Okay. Anything else? Anything else बच्चे? With ketamine we use in ketamine, basically it is not angry baby child syndrome. In ketamine there will be emergence reactions, that is emergence reaction. Okay. Okay. हेपेटाइटिस बी माइक्रोबायोलॉजी में नहीं पढ़ा बच्चे, हेपेटाइटिस वायरस. बेसिकली वैक्सीन्स के बारे में ना, दे नो बेटर. आई नो अबाउट द ड्रग्स, दे नो बेटर अबाउट द वैक्सीन्स. मैं गलती कर दूंगा, मैं प्रैक्टिकल चीज़ तो बता दूंगा बट थ्योरी में गलती हो जाएगी, इसलिए बेटर है कि अबाउट दैट माइक्रोबायोलॉजिस्ट पीपल विल टेल यू. Which one? Toxicity of drug plotting graph. कौन सा भैया? समझ में नहीं आया यार, कौन सा टॉक्सिटी की बात कर रहे हैं. Okay, so monoclonal antibodies, only few antibodies are important, especially the rituximab, tocilizumab. So जो लेटेस्ट एग्जाम में आई हुई है बस उन्हीं के बारे में याद रखो. स्पेशली रिटुक्सिमैब टोसिलीजुमैब पे बार बार आता है. टोसिलीजुमैब पता होना चाहिए. टोसिलीजुमैब इज द इंटरल्यूकिन 6. बाकी आयनाइसिटी के लिए इंपॉर्टेंट है, नॉट वेरी इंपॉर्टेंट फॉर नीट. आयनाइसिटी में फिर भी पूछ लेते हैं. ओके, सो प्लीज रिवाइज दिस टॉपिक्स एंड आई विश यू ऑल गुड लक. अच्छा करो, कीप रिवाइजिंग, कीप स्टडिंग. और इंस्टाग्राम पे मैं जो है क्वेश्चंस पूछता रहता हूँ, उनको भी आंसर दे सकते हैं आप. सो दैट्स ऑल. थैंक यू, बाय बाय, टेक केयर बच्चे. नमस्कार, गुड नाइट.